Ashish has had a formative role in our own institution by creating an app lab, by working very actively with the digital startups in the New York ecosystem, and he will engage in a pretty vibrant discussion. Ashish?
Thank you so much, Scott.
Yeah, so you'll see questions pop up.
That's fabulous.
Just a reminder, the QR code will show up again in a minute, so go ahead and send your questions, and Dr. Atreja will see them here and try to engage the panel in answering them.
Thank you so much, Scott. Linda, your talk was a perfect segue to what we want to talk about is there's so much innovation happening outside. How do we really bring it into our health system? So thanks for setting us up perfectly. I'd like to welcome our panelists to come on stage. And it's my pleasure to actually welcome you to this panel, Adoption of Digital Technology in Healthcare Systems, Models and Strategies to Engage Startups. A long title, but hopefully we'll get to some great summary within 40 minutes. And I really want to encourage you to use the QR code and to submit questions. I know there are a lot of entrepreneurs out here who have similar challenges in getting their innovation adopted by health systems. Oh, yes. So it's Anil. David, I think you're here. So these panelists are actually very unique, and there's a reason they are invited to this panel. They represent what we call as the 4 pillars of innovation and how innovation comes into a health system. So Anil is an entrepreneur, and you can also call him intrapreneur, who has become entrepreneur. And Pravene is a health system CIO. So we have both of those people out there, along with an accelerator person and a venture capitalist. Because really to make something happen, these all forces have to align. And we want to have all these perspectives to see how we move the needle in adopting digital medicine. So we want to be one of the most engaging panels in this conference, which means everything is allowed, which means it's okay to have difference of opinion. You can have hitting exchanges, as far as there is no below the belt hitting.
Without the hitting is okay.
I will start off with just 3 slides just to set the stage of why this issue is so important. Right? So innovation is just happening at a tremendous pace, right? We really feel there's no problem in innovation in digital medicine space. There's more than 165,000 apps in health and fitness today. And just to remind, in 2010, iPad came. So it's only 5 years and we're seeing this much growth, right? But we also are seeing much more alignment in the health systems really finding the need of adopting digital medicine. Accountable care is here. The telemedicine parity laws are already approved for more than 50% of the states in US, and including New York State, right? So this technology is becoming mainstream, and some of them have real good potential in changing patient outcomes. But we really believe the bottleneck is not at the innovation stage. The bottleneck is adoption of that innovation by the health systems, right? So if we do an internal scan in any one of our health systems, I cannot point more than 1 or 2 examples where any innovative technology has become mainstream, where it just touches majority of the patients with one single disease. Just handful of examples. So I think we have a responsibility not only to foster innovation, but actually to make sure innovation touches our patients' lives. And that's gonna be the main premise for today's panel. So I wanted to have a quote which I heard from Epic user group meeting. I have 30 pilots which I need to do. It takes me 6 months to even start a pilot. I do not have 15 years in my life to do these pilots. And that's a common issue which we hear from everyone. This is something that we have been doing for the last 3 years at Sinai App Lab. When any new innovative technology comes or a startup engages, we actually say these are the 7 steps where it has to go through before it becomes essential. And we are all familiar, we initially explore which startups are there. We engage with them, do a demo, or have them come over and talk to us. And then we kind of evaluate the technology, whether we give it to a handful of patients, or subject matter expertise, or we kind of do a very small pilot, right? But really what needs to happen is the 4 subsequent steps, which many times do not happen. And there's a famous thing that people say, it's called death by pilot. You do a pilot, either before you engage with the health system, you run out of money, or this pilot is not going anywhere, you run out of the money, or you do a pilot and you don't go anywhere after that, right? So we really want to move the needle by evolving the solution, partnering with startups, or innovation, whether that's coming internally or from outside, embedding them into our ecosystem, including EHRs, expanding them so it's not limited to a handful of patients, but to entire patient population, consistent with our strategy of no patient or provider gets left behind. And then 3 years later, we'll say, oh my God, this is so essential. I cannot think I can provide the right care to my patients without this telemedicine or secure messaging or something that we believe has got embedded into our ecosystem. I'm very happy to announce we're starting a campaign called as eHealth, called as Network of Digital Evidence in Health. We are trying to bring provider champions in different specialties from all hospitals together to kind of share the evidence in digital medicine and actually to discuss the evidence through a LinkedIn group. And then we are bringing in early 2016 journal just focused on digital medicine evidence. The reason is we all do all these pilots in parallel and we never share the knowledge. So I am doing the same pilot, or Sinai is doing the same pilot, which Stanford is doing, which UCSF is doing. And if we have a platform where we can share the learnings, we can all rapidly grow instead of doing the same pilots and again, which takes a lot of resource. So I will encourage all of you to actually go there and sign up for newsletter or LinkedIn, because we want to have an ecosystem where we engage with you on a continuous basis using evidence as the platform, rather than we don't want to die off this discussion just with this meeting. So with this note, I will ask our panelists to introduce themselves briefly, their background, what they're doing in digital medicine, and maybe pick one specific instance where you had a challenge in getting your technology adopted into healthcare system. So Anil, if you want to start off.
Sure. Well, good morning, everyone. And Ashish, thank you for the invitation to be here. I think it's a very timely topic, given what's happening in the industry. My background, I'm an internist by training. I started my technology career as a biomedical engineer, graduating at Northwestern, and then after Northwestern Medical School, arriving at Cleveland Clinic for residency training in a time where we had paper charts, we had traditional radiology, and as an engineer and as someone who happened to be very closely aligned with computers and technology, I got very quickly involved with the health IT space, was on the EPIC rollout program. My clinical practice was usually one of the, quote, as Ashish put it, one of the pilot areas, and we definitely did have death by pilot in many cases. We also saw innovation come and go, and one of the areas where I got involved with very early on, I was also involved in research and quality, and oftentimes we would have to essentially rely on paper chart reviews, or when the EMR came, EMR chart reviews instead of looking at the back-end data. So very quickly, I assembled a group to leverage the back-end data and perform secondary use projects, including quality and research. Much of that technology, we wrapped it up as a series of applications that we eventually, through the work with Cleveland Clinic Innovations, spun out as a company called Explorys. And since the founding of Explorys back in October of 2009, we've lived sort of the startup challenges and successes, and back in April of this year, we got acquired by IBM to form Watson Health. And Explorys plus Vitel plus a whole host of traditional IBM assets, including partnerships with Apple Health, HealthKit, CVS Health, J&J, and Medtronic form Watson Health today. So I think what I will be hoping to do is sort of give you some perspectives of having lived through being involved in creating a startup, through the maturation process, trying to get our technology and our solutions, and I rarely ever talked about getting our technology in places, I'm always talking about getting our solutions in places, from the perspective of 23 health systems that are currently using our system today. In terms of challenges, we often talk about adoption and pilots, but we tend to mix up the technical feasibility with the value drivers. And oftentimes, the decision makers who sign a contract with folks like Explorys or with Watson Health are not the ones who are actually going to be the ones who have to adopt it and to use it and to drive value. And so one example that comes to mind is when we were in a room full of folks, I think 9 or 10 C-suite level folks who absolutely loved our solutions. And then they said, this is great, we'd love to move forward. Can you come back in about a month and meet with some of our providers and our community physicians? And it was like they had never really talked to any of their enterprise organizations. So one of the challenges is that when you made the sale, and in the case of a startup trying to put technology, once you've sort of gotten the buy-in from the leadership, that's when the real selling begins. That's when you have to drive the value to each and every user, very carefully distinguish between the technical feasibility of making sure you're not going to break the process and then very quickly go into value. And so this lesson that we learned was taking it from the buy-in of the entire C-suite and narrowing down the scope and having a single group practice adopt our solutions, drive value, and let them be the ones who are driving the sort of the value to the rest of the enterprise organizations. Much of the successes we've had have been done so through, in many cases, realignment of misaligned incentives. I saw you bring up value-based care. Value-based care as a driver for startups, with no matter what kind of technology, requires the realignment of various stakeholders, the hospitals, the providers, the patients. Not everyone is going to see the same value all the time. So sort of the examples would be spending a lot of time realigning and get away from technology to focus on people, process, and politics, and then let the technology, whether it's a startup or a mature company, come in to enable all that to happen. That lesson can be repeated over and over again in pretty much all our activities.
Thanks, sir. Pravene, brief background about your engagement with digital medicine and the challenge. And you have a very different perspective, which we really welcome.
Well, my background begins, it's a bit similar to Anil's. I'm an atypical CIO in that I come from clinical practice and informatics rather than from pure technology or business. I studied biomedical engineering as well and did med school and residency in emergency medicine. When I was in medical school, I also remember starting the day by transcribing vital signs from clipboards outside the room onto note cards and copying lab test results from a green screen system onto those same note cards to recite them on rounds and then later copy them back into a paper chart if we could find the paper chart when we were writing our notes. And I thought there's a lot of opportunity here. So maybe health IT would be an interesting field to work in. So I was actually in New York for my residency in emergency medicine at NYU in Bellevue, which at the time NYU was merged with Mount Sinai. I don't know if those are called the dark days or what's thought about that. But at the time, I remember coming up here to this campus to knock on the door of the then chief information officer and plead for the opportunity to work on some projects as a volunteer, and eventually got to do that. One thing led to another, and I was working on a big clinical system implementation and became the chief medical information officer focusing on adoption of technology when the main goal then was implementing electronic health records. Went to Stanford in 2008, worked as chief medical information officer, and now for 2.5 years have been chief information officer, taking on the challenge of managing the IT portfolio. And I would say, right now, in addition to supporting growth, which is a huge part of what we do, we have two big strategic imperatives that I think about all the time. The first is how do we deliver a premium experience to our customers when our customers are captive, internal physicians, nurses, employees trying to deliver the best care possible for patients in an environment where enterprise software on its best possible day is mediocre. And that mediocrity spans beyond the experience with the electronic health record. But as bad as people may feel the experiences with the electronic health record, take a look at some of the other enterprise software that people are using every day. We support 500 applications that run the business. So we're trying to break free of that and deliver a premium experience for people who come to Stanford, whether it's to learn, to practice, or to be a patient, an experience worthy of the Stanford name. And the second strategic imperative is really driving the digital transformation of healthcare, because we believe doing that successfully must embrace the complexity of the system, must be close to what our core capabilities are. Our core capability is delivering healthcare, so how do we engage people with us through their lives? Not through one or two apps that are glitzy and say, download this, it looks cool, but how does it really connect you with what we do every day? And for that reason, we've built our own front-end platform, our own app, and our own portal for patient engagement. Of course, it ties to the back end, our Epic infrastructure, but I'll talk more about that and would like to use that as a basis for contributing our perspective to how we drive digital health innovation at Stanford. I think just briefly on challenges, and we can come back to this, but I like the comments I've heard so far about pilots, and I think one of the, from the perspective of a CIO, and when we tried, if you go back to that premium experience and you think what we try to do is differentiate with technology, and we have to pick good vendors, make those projects successful, and what we do most of the time, frankly, is systems integration. And when someone comes along and says, I'd like to do a pilot, you know, we're not exactly set up to understand what that means. And we start asking a bunch of questions about that are related to implementation, and that pilot turns into that 15-year problem because we're trying to do something different, which is apply an implementation methodology when the real question, I think, is can we test whether this idea is valid, whether this idea has merit? So what we're trying to do about that is be very clear that a pilot is not the first stage of an implementation. And therefore, a pilot shouldn't, when it's done, be viewed as a poor implementation. Rather, it should be something very specific, constructed in a different way to answer a question, and then actually go away. The pilot should go away, and if there's something else that needs to be done, such as scaling, that's an entirely different problem.
That's great. David, if you want to elaborate, and I'll come back, Pravene, to your point about pilots and then making them mainstream.
Sure. Good morning. My name is Dave Whitlinger. I'm the executive director of the New York eHealth Collaborative, or NICE. I started in the healthcare world actually from a different place. I started at Intel, a chip company out on the West Coast. I spent a lot of time at Intel Labs, lived through the dot-com era. We did a lot of intellectual property development, a lot of wireless technologies, a lot of innovation. From there, got into healthcare and eventually decided to leave semiconductors and got recruited for this role. The New York eHealth Collaborative, if you're not familiar, we are the governance nonprofit organization that is responsible for getting together the statewide health information network for New York, the clinical record exchange across the whole state. We have been a little bit quiet about this, but in the last 3 weeks, we have completed connecting all of the RIOs together across the whole state. So records are now available from Buffalo to Long Island. And that's a rather massive policy, technology, and business project that is quietly reached fruition. As adoption grows, we'll talk more about that. We also, as you're perhaps aware, run an accelerator program. And the idea behind that accelerator program is that if we think of the network as electricity, as the public utility, as a public good in the same way as a public utility, that at some point we expect to have all kinds of tools on top of that. You know, when the electricity infrastructure started to get built across the country, that enabled innovation to happen in the form of stereos, toasters, computers, and the like. This is what we think is missing in this ecosystem, is this standardized platform for all of these applications that readily innovate on top of, readily build, and allow for that rapid iteration that is really necessary in an innovation environment. So we built an accelerator program with the Partnership of New York. It provides startups with 3 key ingredients: access to healthcare provider organizations. So all the marquee brands, including Sinai, are part of the program. They sign up to essentially evaluate startup companies and do pilots with them and give those companies key feedback on their products. Capital. So we have about 5 or 10 investment VCs that are part of the program that also kick in capital and will provide capital to these companies as well as mentorship. And then lastly, access to data and hopefully a better way of doing that. This program is now in its 3rd class. About 25 companies have come through it. Most of those companies have either merged or received additional startup rounds. Around $50 million has now been acquired by the various startup companies through additional rounds, and also creation of several hundred jobs, high-tech healthcare IT jobs here in New York. So that's our portfolio. A couple of things that we've learned from that. One, startup companies just do not, startup healthcare ID companies are really having a tough time and a bad fit with large enterprise-sized institutions. And for a couple of reasons. Large enterprise institutions want to behave in a sense of, and particularly in healthcare, with pilots and evidence base and all of these kinds of things from traditional approaches for making decisions about purchases. And that's not the rest of the world. That's not the way most high-tech industries operate. There is a try before you buy. There's a lot of rapid innovation. There's a lot of test things out with customers for a couple of weeks and move forward. That's not how, as we know, healthcare and large enterprises work. They follow more of a traditional medicine approach to decision making. Not all healthcare IT is about evidence-based decision making. It's not about delivery of care. It's about improvement of the patient experience, or improvement of the enterprise workflow, or improvement of efficiencies of the system. But unfortunately, a lot of the decision making that we see follows that old paradigm of evidence-based decision making. It's unfortunate because startups die. They don't have the capital to live through that. We also see that the contracting process from large institutions is deadly. You get a bunch of lawyers, you get a bunch of liability, and you throw them at a startup company, and they can't possibly survive some of those contracting conversations. It's not even 800-pound gorilla versus a gnat. It's just ridiculous sometimes with the struggles that the startup companies face when dealing with the corporate lawyers who are really reticent to allow a little startup to play with their data in order to help patients. It really creates a challenge. And then lastly, I think is, if they can survive that juggernaut and actually get the product out there, the interoperability, the interface, the connectivity, and the integration to the systems can also be the next place to die. That cost of integration is really, unfortunately, abhorrent. I'll just take one more minute to say that I think that I was back at Intel during the digital photography transformation, so from film to digital photography. And it's not widely known, but Intel Labs spent quite a bit of time on this project because if you got people sharing photos, they were going to use computers to do that, and you'd sell more computers. There were a couple of key technologies. USB came out of Intel Labs. A lot of software came out of Intel Labs. But the one key enabler that caused that whole digital photography ecosystem to explode was the JPEG file format. Having a single file format that if you hand it over to this piece of software, it can ingest it and do editing. You hand it over to this piece of software, it can ingest it and display it. You hand it over to this piece of software, and it incorporates it into a document. It was the single most significant enabler for all of the digital photography for personal transformation. I would submit that the lack of true standardization, emerging but true standardization in our healthcare IT field is one of the single most limiters to innovation because of the integration experience is so costly, so painful, and it's a one-off for every customer. If that CCD, if that HL7 document, that JPEG equivalent were to be ubiquitous across all the software we use, then we'd be a different experience.
This is great.
Thanks.
Thank you. Dan, your perspective will be great, and we'll talk about other questions as well for barriers.
Yeah, thank you, Dan Gebremedhin. Thank you, Ashish, for having me, and thank you for giving us this opportunity. I'm a member of the investment team at Flare Capital. Flare is a $200 million venture fund headquartered in Boston. We are healthcare technology only. We raised a $200 million fund primarily from strategic investors, so large corporate entities in the healthcare space, some of the kind of best payer, provider, PBM, and health IT companies in the space. I'm an internal medicine physician, trained at the Mass General, and still on faculty there in internal medicine. I have about a kind of 360-degree view of this space, having been a user as a physician, having been an entrepreneur and a developer of some of these technologies. Spent several years as a co-founder of a company called Implement HIT that does EHR systems integration and clinical documentation, and then as a purchaser of these services. I spent 2 years as a medical director at the Harvard Pilgrim Health Plan, which is a commercial health plan in the New England area, as a medical director focused on population health analytics, revenue diversification, and spent a lot of time working with early stage healthcare technology companies in trying to sell into payers and then inadvertently kind of selling into employers and ultimately to our beneficiaries. And then now as an investor here in healthcare technology. I think the panel has brought up a lot of great, kind of challenges. And I think as investors, what we see oftentimes is different models that are successful and some models that are not successful. A lot of what investing is, especially in the early stage phase of the industry, is pattern recognition. And so I wanted to kind of provide a few ways to mitigate some of the many risks and challenges that the panel has brought up, specifically around the point that David brought up with regards to privacy and security of data. Oftentimes, whether it's a provider system or a payer, they hold very sensitive PHI, and there are a lot of security risks. There are a number of ways to mitigate those risks that we've seen some of our portfolio companies achieve, specifically around developing very strong HIPAA business associate agreements. Oftentimes you have to spend time with a lawyer to develop these, but if you have a kind of a standard document that you can, at the forefront, kind of present to your potential client, that can definitely mitigate that risk. There are a number of technology standards, such as high trust, that if you are going to build your technology, that you have to make sure that you implement into your platform to kind of mitigate, the perception of, potential security threats. To the point of kind of these concepts of pilots, and oftentimes really what it is it's a long decision cycle. It's a long sales cycle when you're selling into an enterprise client, oftentimes because provider systems tend not to have a single decision maker. It tends to be decision making by committee. And then there are ways to mitigate those risks as well. I think the benefit that startups have is that they can be nimble. They can have innovative and flexible contracts that aren't very standard as opposed to, say, a large kind of enterprise level technology company. And these are things that startups can use to their advantage to kind of custom fit a solution to an enterprise client. And then they can be creative in their contracts to make sure that you're not doing an unpaid pilot, that there is a paid pilot, and there are certain kind of clauses and triggers that convert that paid pilot into an actual becoming a paid customer. So I think that there are ways to mitigate some of the many challenges that the panel's brought up.
This is fabulous. I think just to summarize, we saw multiple things hit again and again, and one of that is interoperability issue. And I would say it's not just, David, what you pointed, the data interoperability, like the JPEG example, but also operational interoperability, right? Everyone has a different contract, different legal specifications for HIPAA. And for a moment, I would like to have you imagine that you are in Silicon Valley. Okay, it's not raining out there, Linda, but I'd like to take you to there and kind of take you to the world of startups, how they engage with accelerators. So every startup for investment, for angels or seed, they actually went through the similar process where there were multiple kind of people on the table, and there were multiple kind of contracts, legal contracts for equity when you are in a startup. How angels will say, I'm to take this equity, how you value a startup, right? So it was all over the place till Y Combinator came with a SAFE model, right? So it's a simple agreement for future equity. It is a 5-page document, and they made it completely open source, right? So then Techstar came, and they also made open source their document. And that really changed the conversation because there was just 5-page document, and that said, so for example, we can take to a startup here, based on your maturity model, and for a health system, what health system has to invest to do a pilot, this much percentage equity, or no equity, but this much percentage of revenue discounted in the future if we decide to go with a pilot. So you can actually have a variation of a SAFE pilot, of a SAFE document for healthcare systems, which will streamline the process of how startups can engage with any health system. Right? So right now, everyone has a different policy. If someone has to come to Stanford or to Sinai, the way we engage, the documents we request are very different. If we create a standardized toolkit, which even 5-6 health systems agree on, with parameters which we can modify and tweak, would that be a useful contribution that we can bring to this startup world? What do you think, Pravene?
I mean, it's hard to argue that such a model wouldn't be helpful. I'm thinking about our own experience in that, and imagining myself in Silicon Valley, where I'll be tonight. I think you know, our institution, I mean, you know, we have a lot of conversations that's, for example, do we want to be investing in companies? And there are health systems that have venture funds or spin-off venture funds. We don't exactly do that. We do some of that through the university, but I think there are peculiarities of places that are going to make a standardized process for reaching these kinds of agreements difficult, because our interests, I think our interests can tend to diverge. For sure, though, we can make it more transparent. And we've tried to do that, and we have some more work to do. I mean, it shouldn't be that, and inevitably it was, but it shouldn't be that the process of evaluating a startup technology is an exception process. It shouldn't be that you're dragging somebody off of their otherwise, you know, their day job and saying, could you please go do this, because it never works well, and then no one knows what's going on. So we do have dedicated people. Their job is to do these evaluations. They have a standard methodology. They know what our interests are. I think we could do a lot to make that more clear to companies that want to work with us before they even start. So I would suggest that that would be a beginning. And if we do that, then we might find the common ground that we share with other academic medical centers.
Interesting. David, what do you think? Or Dan, would you like to comment? I mean, from a perspective of a startup has to engage with multiple health systems, right? If each one has its own processes, it takes time to learn the process. And if we can work together as health systems in getting a common, at least a starting document, would that help you as a venture capitalist? Would that help you in your accelerator space?
Yeah, I mean, I think, you know, kind of the format that you're describing, I think would be helpful. You know, my sense is because you have very long sales cycles in each of these large entities, they're all essentially kind of going through the same set of processes and kind of you know, value checking, you know, whether or not the startup kind of has that staying power, whether or not they have the kind of security parameters to actually do business with a health system. I think oftentimes when health systems are approached by startups, I think the first thing that they see is risk. And so I think that if there is this kind of standard, you know, kind of checklist, if you will, I think it would definitely speed up the process. I think as investors, you know, we try to be helpful to early stage companies through, you know, introductions with, you know, kind of C-suite individuals at these institutions. But that only goes so far. Because ultimately, as you point out, it's the same kind of you know, measures that, you know, many of these health systems are essentially you know, trying to diligence on. You know, at the same time, you know, many different health systems, as Pravene pointed out, do have corporate venture arms and will engage with startups. And when they like a technology, they will invest. But I think many more health systems tend not to do that. And so I think, you know, kind of having a standard process would be helpful. One model that we have seen, the Brigham and Women's Hospital in Boston, has their own accelerator, has their own kind of hackathons where they will kind of open themselves up to a certain extent to invite startups in. And so that, I think, is also a very interesting model in which, you know, health systems can open themselves up to innovation.
That's fabulous. Are there other examples? David, if you want to comment, and then I want to see, are there other examples who is doing it really well that we can learn from and adopt as a practice in other health systems as well? So I know you mentioned Brigham Women, and accelerators can only take that many companies, right? So the challenge is we saw 165,000 apps, right? They don't even include variables. They don't include other aspects that are coming, right? So there's much more coming than 5 or 10 pilots you can do in an accelerator within a corporate venture. Is there any organization which is doing good?
Well, you know, I think it depends on what the doing well actually means, right? I mean, so we evaluated formally 200 companies in the last year through our processes. And from that, so I think the evaluation part, we're doing pretty well. In terms of finding the value proposition there are very few where the problem set matches the one that we want to do. So I think if the question is picking winners, you have to look at places that have made the spin-off mentality, I guess, a part of their culture. I certainly look. I know that, for example, I think of UPMC as a place that has spun off any number of companies, and I suppose that's one measure of a place that's doing something well.
Anil, what do you think in your exposure to all health systems? What do you think has a much more streamlined strategy which we can all learn from?
Well, I'm a little biased here.
If there is anyone.
I would think the Cleveland Clinic with their Cleveland Clinic Innovations group, I think, has done a good job of trying to incubate and then demonstrate value. They've also done a good job of letting others come in and understand the value that the Cleveland Clinic may be providing. And as you put it, Ashish, asking for either some sort of equity or some sort of relationship with that company. So I think there are other examples. I'm certainly not an expert on that, but I would caution us to not come up with a cookie cutter mentality or a template-driven approach, because one of the mainstays of innovation is the freedom to explore different types of opportunities and relationships. So where it might work, in some situations, there should be the freedom to sort of go outside the envelope and think about what may be on the edge of relationships between healthcare systems and entrepreneurs or startups. Because I suspect that as every health system is different culturally within its four walls, the innovations groups and their tolerance for risk, their tolerance to be in this business. After all, they're healthcare companies, and now they're taking on risk with other companies. It's going to vary across the U.S., and so we ought to have a balanced approach to a template-driven approach and give a lot of freedom to the entrepreneurs to come up with some creative ways to engage.
Yeah. I was thinking a little bit more about your question. I think that, as you were saying, that the challenge, I think, is we do have federal law with regards to data use, privacy, and security, and that's in HIPAA. And to the extent that some institutions say that's good enough and they fall to HIPAA, then there's ability to get consistency and there's ability to have agreement. But that with most big institutions that ultimately have deep pockets that can be used for liability, they have higher standard with regards to privacy and security, and they're all over the map. So it would be challenging. If everybody fell to HIPAA, and if the federal court system and the state court systems essentially help manage to that, then it'd be a different story. But I do think it'd be challenging.
Thank you.
Just another comment. I think that we get stuck in not understanding what we're trying to do. And are we trying to validate a piece of technology and answer a question, or are we trying to get it sold to an enterprise? And really trying to draw that distinction whenever possible, I think is going to be important. I don't see the opportunity for us to, for example, go to a de facto standard of one business associates agreement across, that's standardized, that every institution views the risk the same way for the reasons that we've heard. And that's, and when a startup comes to us and says, I kind of heard the expression like, we want to play with the data to answer a question. That scares us, right? That just play with the data concept is too scary. So we have to somehow lower the risk of that by constraining the conversation in a way that the risk gets more tolerable, that we don't necessarily need the same business associates agreement that we would otherwise use for a vendor. We need to create a sandbox that people can come and play in. I don't think health systems are going to generally say to any entrepreneur when they come and say, can I just have your data to answer some questions? We're not going to say yes anytime soon. That's just not going to happen. We need to come up with a better answer. This is come inside with us. Tell us what you want to know. We have a safe place where you can do this, and when depending on what you learn, then we can talk about the business terms that may come out of that. And maybe that's maybe that's another opportunity for collaboration, right? To say that we create this environment. It doesn't have to be just a Stanford healthcare environment. It could be many academic medical centers. The more data we have, the better for everybody.
Right.
But I'm constantly thinking, how can we work together to lower the stakes?
Right. The risk is coming up time and again as it comes to adoption. I want to touch upon your point and also that very important question that has come up from the audience. What are we trying to do as a health system? We know there's many discussions that the whole purpose of a pilot, I have heard this time and again, of a startup company is to go from point A to point B, get from seed to series funding. And they don't really care sometimes about creating the value. I think that's a biased representation, but there. But it touches upon the central issue. And this has come up from a question, how do the altruistic goals of nonprofits coexist with the very different needs and agenda for the for-profit startup world? And I know it's a philosophical question, but I think, can there be a value stream where the for-profit agenda, moving them down the ladder, creating success in some way also aligns with the value we want to create within our health system, right? And I know it's an open-ended question, but and I know many people like me who are within a health system struggle with that process in terms of, yes, there's a motive for them, but I have to stay true to the health system, and it also touches on the evidence thing. So I want to open up for anyone who wants to take a shot at this.
I'll take a small swing at it. I think, there was a period of time, and we're still living through some of this, but it's starting to transform because of the payment system, where innovation from a health IT perspective or in the digital health era or environment was all about trying to find an insurance code that you could get reimbursed for. Right? You were not going to survive as a startup unless somehow you could figure out how to get payment from the insurance companies. And that resulted in you trying to come up with different products that met some sort of code in the insurance system such that you had financial viability. Now we're shifted, of course, to value-based and other kinds of payment system, and the provider community is now in the space of trying to judge whether or not something is going to add value or not, and whether or not it's ultimately going to pencil out. And as we know, in many cases, this is a brave new world. In many cases, that penciling out is years down the road. Mm-hmm. There's going to be these kinds of problems that are being solved in the healthcare system are not things where you expend $1 in 1 month and you see a return on that investment in the same year. It's many years. And so organizations that have the financial resources, call them nonprofits if you will, but organizations that have financial resources, they are going to have to stay in it for the long haul to see what happens and get the results. And there are going to be some good bets and some bad bets, right, but hopefully more than good than bad.
Right. And part of that conversation, just to steer the conversation in that regard, is could there be an understanding when the pilot is done, before the pilot is agreed upon, that if the pilot, first the success metrics for pilots with the timelines are clearly defined, and if the pilot is successful, these will be the benefits that may come back to the health system in terms of whether it's a discounted rate or something of that nature, and that may allow a win-win, where the health system really is putting, this is what value proposition we can do, and we're ready to put kind of initial hit or initial resources into it. Pravene, what do you think?
I certainly think that's possible. And just to a bit more on your, related to your question, I think it's a good point. We're very comfortable taking all of our data, putting it into repositories and tools that support the research mission of the enterprise. I mean, as a health system, we exist as an academic medical center because we support research and education. And that's easy. We move, it's not easy, but it's well accepted. We don't talk about it, we just do it.
That's right.
And when it comes to figuring out how we do that with entrepreneurs, it's a little more difficult. At a place like Stanford, it's more clear because that's the whole culture of the place. One of the challenges is that when we engage, so often we don't really understand what the relationship is supposed to be. So, and as a bit of a tangent but related, an entrepreneur will come to us and say, I had this experience as a patient, or my loved one had this experience as a patient, and it was terrible. And I want to fix that problem in the health system so that no one else has to go through it. And no one can argue with this because they tell you these stories, countless stories, and it breaks your heart, and you're part of the health system, and you say, it's terrible that that exists. But the entrepreneur is trying to solve without really any knowledge of the ecosystem, and ultimately often is delivering what I think they think is a B2C solution. In other words, they're trying to deliver it to the end consumer, the patient, and then sell it to us as a B2B solution. So there's this confusion about, in many cases, is it a B2B play or a B2C play? And what's the difference between the user and the customer? And so again, this is like this. So if someone comes to us and says, I'm selling health IT to a health system, that's what this conversation is about. Then, okay, we get what that is. But when someone says, you please deploy this tool to change the way consumers interact with the health system, but and tell us how you might pay for it,
Right.
That's foreign territory.
That's correct. And I think, Dan, you had some perspective on that?
Yeah, I mean, I think to answer the nonprofit question, remember it's a venture capitalist answering this question. My sense is it all depends on your definition and how you think about a nonprofit, right? I mean, ultimately, nonprofits can be businesses, right? And I think when nonprofits have to think about sustainability, you have to be efficient, you have to be effective, you have to ultimately fund your mission. And so my sense is, there are opportunities for nonprofits to commercialize their assets, such as healthcare technology, that can fundamentally, sustain and support, their underlying mission. And I think there are opportunities to do well by doing good. But to your point, I do agree. You have to start to think about once it gets to a certain stage, do you spin it out? Do you license the technology? I think that's a really important consideration. But just because it's a nonprofit does not mean that they can't, effectively, succeed in business.
Absolutely. Just a brief comment, David, and there are great questions coming from audience as well.
Yeah, so I mean, the one thing that I hear on this table at times is our data, and that coming from the institution, meaning our data. And I think that it would be interesting if we were to think about that really is, it's not the institution's data, it's the patient's data. That is what HIPAA says. And to the extent that the institution feels like it needs to overtly block innovation on top of that data, perhaps, because they were in the name of being good stewards of the data, what about asking the patient? What about making that part of standard procedure on admissions, making that part of standard procedure as a patient is going through their healthcare experience? And for those patients that say, I want you to get health innovation out of my data, use it widely, freely. Don't put your lawyers between this and Silicon Valley. Go do something. Those guys that have a loved one that got hurt and now they're trying to change the world, those are the good guys. We want them to go succeed. Let's take some of the barriers away. It's not your data. It's the patient's data. Ask them, and they will want the innovation to happen.
So this is very interesting because we have been doing this for research registries, right? So we have research registries where we tell patients, and the patients give a consent, not only you can use the data for this specific research purpose, but you can actually use not only data, but my biospecimens for any kind of related or unrelated research, right? So that perspective we already have. And the question is, as innovation comes, can we have the same kind of a paradigm for innovation as well? And coming to Linda's talk, while she's reaching out to consumers directly, maybe through health systems there can be a platform, but health systems have to gear up for that, right? I want to take the opportunity for a few people who've raised questions. Do you want to come in person to ask questions? I know Omer has a question and Nigam has a question, or you want me to speak out your questions? You can go ahead and ask. Okay, Omer. So Omer's question is, what role do you see for local government entities such as NYC, the HHC, in facilitating pilots and interoperability? So there's a very interesting perspective from Omer where they are looking at communities like East Harlem community and want to increase the health and wellness on those communities. And they are now interested in using the digital medicine tools to actually get into communities. And they want to be part of this conversation and help move it. So I think maybe, David, you can probably address this in terms of what role New York City or NYDC or other HHCs, which are family health centers, partly funded through the NYC Medicaid, how can they move the needle and get maybe consortium together in some understanding? Omer, is that something? Okay.
And let me see if I'll try a few different angles. With the SHINY, the State Health Information Network in New York, about 29 million patients now are, their records are part of the statewide network. And that could be one record or the last 5 years worth of medical records for those 29 million people. As this now starts to build over the course of the next year, we are looking to put an API on top of that such that it will, in a standardized way, allow the data to get accessed by entrepreneurs. Again, patients giving consent for their data to be used by many. That we think is going to start to one, crack open the ability for innovation to happen on a standardized platform and maybe get us to that era of the JPEG and the innovation. With regards to clinicians and usage of the data today, that's through patient consent. That's all widely available across the provider community. So we're looking forward to more being done with that each year.
Yeah, and just wanted to add to that. I mean, I think, it's like an example, a microcosm of this concept of a public-private partnership. I think there are a lot of great examples of that at the highest stage, the White House bringing in Optum to do healthcare.gov. At the startup stage, not a portfolio company of ours, but a very interesting company in the Boston area called Patient Ping that is working with health information exchanges to, kind of as David mentioned, kind of create this kind of API to make it very usable, accessible for interested stakeholders such as provider systems or payers. So I think, continuing that concept of, kind of working with, kind of governmental entities that have access to a lot of data, but may not have the technology or the bandwidth to make that data accessible and use for commercial purposes.
So extending this thought, Omer, I think the government or NYC, for example, can do a great perspective in bringing different people together, including competing health systems, because there's no great forum where competing health systems can come together for a community. And I think even starting at that node and getting everyone on the table, including accelerators and health systems, and maybe a few startup companies or innovation out there, would be kind of a great step in extending dialogue. How do we extend our stuff, what we are thinking, to health systems, to the community, using the ecological aspect? There's one question from Nigam, which I think is very interesting. We talked about all the barriers, and we kind of made the health systems look bad. There's so many barriers, operationally others. So Nigam had a twist to it. He said, what are the top 3 reasons a health system will say yes to an innovation that's coming in? And I think that's because sometimes we have to play that role as well and say, okay, if we achieve these 3 in my checklist, at least I have a much more better chance as a intrapreneur, entrepreneur, going into and getting adopted in health systems. So, Pravene, do you want to take a stab at it?
Well, I'll give a few characteristics of the things that we like. So first, if the entrepreneur has health system context, has had some time in the health system, apprenticing somewhere, either as a provider or in some way otherwise knows that, and comes in and says, frankly, what's most helpful and the partnerships that have worked the best with some is actually I get that this is a really hard problem. I understand why it's hard, and let me tell you why I think I have some capabilities or an idea here that's going to be different, rather than telling us that the problem is very, very simple, simpler than we realize. I think, so that's one characteristic. When another is actually that for us, what we would be most interested in is if someone comes to us and says, I have a piece of technology that you can adapt into your ecosystem and license from me, as opposed to say, right off the bat, change out your platform or deploy another app or another couple of apps. We worry because we are also, at the same time that we're trying to drive this innovation and support research, we're trying to create an experience for patients that helps drive the business forward. And we don't want to confuse them. So rather than say, here's your app to do this with Stanford Healthcare, and here's another app to do this other thing with Stanford Healthcare, and here's this third app to do this research study, inevitably part of that will happen. But if we could, if entrepreneurs can come to us and say, look, I have an amazing piece of innovation here, and and I ask them, like, okay, is that a piece of workflow? Is it a user interface innovation? Is it content? Is it an algorithm? It should be one of those things or something like that. And then if they say, and I will license it to you to put inside your platform to do something great for patients, those are the kinds of things that we're looking at. That makes it easier for us to work with them.
That's fabulous. What do you think, Anil?
Yeah, I think
from Cleveland Clinic perspective.
Yeah, sure. So we obviously have innovation going on within Explorys and within Watson Health, and we have these conversations. If someone can't explain to you in 30 seconds or 60 seconds what the innovation is actually going to do for that health system's patients or for yourself, if someone can't explain how it's going to simplify the ecosystem rather than complicate it, and how it's going to translate from either, and I hate to use the word pilot, but either from a evolutionary stage to something that's eventually going to go into production, it's difficult to have a follow-up conversation. The problem with doing a pilot and then having it disappear is that you often get a lot of people excited about something. And so if you can't translate that pilot into sustained value very quickly, it's tough. So when people come to me, I look at whether they have a proven track record, whether it's in that field or somewhere else, of translating an idea into execution, whether they have the support of the rank and file folks in the trenches that it's going to actually make their life simpler, and whether they actually have a soundbite that can explain the issue. If it requires a 60-slide PowerPoint deck or even a 10-slide PowerPoint deck to explain the innovation, it's probably not a conversation worth having. They got to be able to very quickly explain it. And so when we look at this, whether it's someone we're internally funding or whether in my prior life at the Cleveland Clinic where we were evaluating entrepreneurs and vendors, it was simply looking at how simple is this going to make life for that system, whether it's within the healthcare workflow or whether it's in the IT back shop.
So David, and I'll twist the question a little bit from your perspective. What are the top 3 features you will say distinguish a company who gets successful in your accelerator or VC model in adoption or in penetration versus which do not get accepted? So.
Yeah, well, minimum price of entry at this stage in the game in New York is just, you have to use the word disrupt. You have to somehow, you have to, I think it is fair to say that, almost all of the New York healthcare delivery system is looking for things that are related to the disrupt payment reform system. And the fact that there's, $8 billion, if you throw in the matching money, $13 billion going into healthcare transformation in New York, that is what everybody is looking for innovation around. And if you are a startup entrepreneur and you're approaching healthcare system and you cannot speak to disrupt and the change and the transformation and the needs and the wants and the aspects of that, then you're probably going to be ignored. It's just, that's the movement. That's what everybody's looking for. And it's the, that I think is, and transformation is broad. So there's a lot of places there. I think also it's clear. There's a lot of people that do get into this space because somebody got hurt and they're passionate about it. But if they have not invested the time and energy to actually understand the complexity, as you say, this is not an easy environment. Healthcare is not simple by any stretch. And the payment, the mechanics, the businesses that are in here are really complex. So they have to have a management team that has obviously done their homework and is solid. And then, of course, the last piece is their innovation has to be something that's going to be useful. I'd say that we get a mixed bag of the provider community sometimes is looking for something that they can just not have to integrate and get going and see, and then maybe integrate and get more out of it later. Or if they think there's something really there, or it only works because it can be integrated, is it worth integrating? Mm-hmm. So it depends on what the app is.
For the audience, just DISRIP is the New York State Medicaid initiative. It's a, I think, $8 billion initiative, decreasing the healthcare utilization, especially readmission. And that's basically something which is on radar screen for all the health system executives, because that's a pot of money that's given to health systems and its partners directly coming from Medicaid. So that aligns the financial incentive very well. Dan, from your perspective, the companies which you can distinguish? Correct?
Yeah, I mean, I think that we've kind of really spent a lot of time on workflow and interoperability, so I won't beat that horse anymore. I'd say 2 other opportunities are kind of really hammering down the ROI and thinking about the value proposition that you are bringing to the health system. I think a lot of the time entrepreneurs think that something's useful, but they can't really quantify how useful it is. And so when you enter into contract negotiations, specifically thinking about paid pilots and pilots that naturally convert, identifying, what is our goal ROI here and how are we going to measure that, and actually baking that into the contract and into your product offering and having dashboards that kind of show the user that it actually is being effective and delivering that value. I'd say the third thing that we haven't really talked about is just understanding the ecosystem of the healthcare kind of value chain. I think oftentimes, unfortunately, entrepreneurs will develop technology that kind of fundamentally is kind of competitive with the provider system. There's a lot of kind of clinical decision support tools, care coordination apps that are just essentially protocols, which kind of take away a lot of the decision making from provider systems. And the kind of value proposition to the provider system is, you'll be able to see, this many more patients, or you'll be able to reduce the wait time, the visit time from 20 minutes to 15 minutes. Provider systems, I don't think get that excited about that. I think what provider systems tend to get more excited about is entrepreneurs and businesses that can kind of extend the reach of the health system outside of their actual own walls. So a good example are companies that kind of focus on care transition. So once the patient leaves the health system, tracking that patient. So in New York, a company that does that, Curator, they're getting a lot of great traction in that kind of care transition space. Patient Ping is also doing that in Boston and giving that health system more reach that they otherwise wouldn't have. And that's just fundamentally not competitive with what the health system is doing.
One of our graduates, by the way.
Yep, there you go.
Fabulous. So in the interest of time, I want to have maybe one last round of questions. And it's a very controversial thing. So if we look at a drug company or pharmaceutical company when it approaches a health system for a clinical trial, that pharmaceutical company actually pays, to a certain regard, to get the clinical trial done, right? In pilots and innovations, that is not happening. Most of the health systems don't get paid for a pilot. They actually have to utilize their own resources. For example, at Sinai, we have a 5 to 6 people team just trying to scan the technology, trying to do all these demos. It's a major, major, major expense without a clear value in the immediate future. Is there a role for a paid pilot, especially if it's more than a minimal effort on the part of the health system?
Yes.
And
People say, again, we joke because people say, come use our technology for free, and we know that costs us $1 million. So I would couple that with the de-risking comment that I made before. I mean, we have to lower the cost of the pilot. We can't do all of the stuff that we normally do when we implement systems, when we're just trying to test something. We need to know very specifically, are we testing the idea, are we testing the usability, or are we trying to test scalability and integration and enterprise capability? We shouldn't be trying to test the second thing until we've already answered the question about the first one. And I think if we focus on that, that can lower the cost, lower the risk, but we do need that help. I mean, it takes a lot of money just for us to look at those 200 companies and talk about doing something with them is much more expensive.
right? Maybe that's the barrier. Anil, from your perspective.
Yeah, so from my perspective, the answer could be yes, but it would have to be done with the same rigors that one would conduct a clinical trial.
That is correct.
And I think most of the time, again, having been on both sides, I've run pilots from the perspective of the health system, and I've asked health systems to run pilots as well. And the rigors aren't necessarily there. The metrics that are being measured often have to do with sort of feasibility and adoption, and there's a soft value equation somewhere in there. And so I think the answer could be yes if we can tighten up the expectations that one has during a pilot phase.
And I think part of the reason the accountability may not be there to that extent is there's no exchange of any money, right? So if there's an exchange of money, then you say, okay, you can also have, like many clinical trials happen, if you meet these criteria in 3 months, then you get this much subset. At the startup, you get this much. And if you finish the complete enrollment and the data from 100% or 90% of the patients, you get this much. So I think if health systems stand up, and that's maybe a trend where health system can say, I will deliver accountability in a metric, in a pilot, which will take you from point A, B, but for that, this is the cost, which I entail, which you have to find as a startup company, whether you negotiate with your funders or you file for a grant, but this is the cost, and I assure accountability.
Yeah, I think also one other quick comment is that oftentimes when the health IT entrepreneur or a company is doing a pilot, there's a lot of contributions that they're making to the project team, either through a project manager or through implementation folks. And so it can get a little muddy a little bit in the sense of, if you have a paid pilot, are the results of the pilot, are they going to be less meaningful, number one. And the second part is, how do you separate out what the health system is contributing for the fair value of getting paid for that pilot versus what the technology company or the vendor might be contributing. So I think if someone does step forth and has a credible model, I think people will be willing to embrace that.
Thanks.
I'm struggling with the analogy and the paradigm. We're talking about pharmaceutical companies that require a massive amount of clinical evidence in order to get through the FDA process and obviously not harm patients with actual clinical delivery of care. There's a small fraction, I think, of the startups that are running around in this space that are actually in that same kind of paradigm of trying to deliver care that actually needs clinical evidence of that stature. I think there's a lot of companies that are working on workflow and efficiency and data management issues and patient engagement issues that don't require clinical evidence to get through an FDA process. So I question the equality there.
Sure. I think we ran out of time to kind of do. Dan, do you have any closing comments?
Yeah, I mean, I think, as an investor, I mean, ultimately we would be funding these paid pilots. I mean, I'd think about it a little differently. I don't know that we'd want to invest in a company that has to pay their customers for them to use their product. I think that the companies that we like the best is they're solving a real problem, and so hospitals are kind of trying to get in line to get access to that solution because it is outside of their technology or their bandwidth to actually deliver that solution, and it's something that they desperately need. So.
Very interesting perspective. So in the interest of time, I may have to just cut short the future discussion. I do want to mention we are actually writing a white paper which summarizes a lot of discussion, and we'll make it available on NodeHealth for commenting. And we want to make it kind of open for community to kind of continue this dialogue. And we don't want to stop this discussion at this point. With that, I really want to thank for such a fabulous discussion all the panelists with a round of applause.